Esophagus. So we need to know these points regarding esophagus. What is the length? What is the extent? What is the histology? What is the relationship with diaphragm? And what is angle of his? These are the 5 basic anatomical points, but important from surgical point of view also. So what is the length? Any guess? It's a tube. Yeah, very good. It's a tube of 25 centimeters in length. Okay. If this is the upper incisor, from incisor to the uppermost end, upper end of esophagus, this is 15 centimeters. And from here to the lower part of the esophagus, this is 40 centimeters. So 40 minus 15 is 25 centimeters. This length, why is it important? Why is so important? That is only 15, this is 15, that is 25. Why is it important? Any guess? Just guess. There should be some reason if we learn something. These are all basic anatomy points, but sorry?
To gauge other anatomical landmarks, important ones.
Okay. Partly right. Any other?
Strictures are present, so that's why.
Yeah, constrictions.
Yeah.
Surgical approach.
Surgical approach. In any other better than surgery? Any other thing? Minimal invasive. Endoscopy.
Minimal
Okay.
endoscopy.
Yeah. If you do an endoscopy, if you plan to do endoscopy, you should have an idea. So if you pass for 15 centimeters, you know that you are at the upper end of the esophagus. Okay. And if you still pass it little down, you will feel the constrictions, which I'll show you next image. So you know where are the constrictions are also. It all depends. It is a numerical value. At certain level, we expect some constrictions. So there will be narrowing. You can't pass your tube freely, endoscope freely inside. So at that point, you have some resistance. Okay. And the other thing is, at these constrictions, what are likely to be lodged in children? I told you what are likely to be lodged in this
objects.
Foreign bodies.
Suppose accidentally if a coin or something is ingested, most likely that it strikes in some of these restrictions only. Okay. That is about the length and it extent from where to where it extends. What is there below? Esophagus opens
continues. It continues as the
stomach. Yeah. So this is the GE junction, gastroesophageal junction. GE junction, we call it as GE junction. And upper, here the pharynx will be there, it opens into the esophagus, pharyngoesophageal junction. Okay. Pharyngoesophageal junction. It is at the level of C6, this is at the level of T10. What is this C6 and what is this T10?
Cervical vertebrae 6. Thoracic.
Yeah, based on the cervical vertebra. And this is the thoracic vertebra.
Thoracic.
Okay, at that level it is there. T6 to T10. Again, I'll show it. And histology, what is histology basically?
Tissue.
The epithelium. The epithelial lining.
Histology, the epithelial lining along with the tissue, the cut section of the tissue. So it has 4 layers in entire GAT. It is almost of 4 layers. Okay, epithelium. That is the mucosa. We call it as the mucosa. Mucosal layer, submucosal layer, then muscular layer, and subserosal. These are the 4 layers. Anytime these in any structure, these 4 are a must. Okay, so those are mucosa, submucosa, muscularis mucosa, muscular layer, and serosal layer, subserosal layer. Okay, so the peculiarity of esophagus is the serosal layer is absent. Okay, all the other layers are present, but serosal layer is absent in esophagus. That is the peculiarity of esophagus. Remember this point. It has a bearing. Why is it important? Can anybody guess? I ask you to guess so that you will just have an idea, so that you will never forget again. If you guess wrong, you will never forget it again. So guess it. Why is it not? So what is the importance of this? If serosal layer is not there, so what is the importance of this? Why are we bothered about? Okay, it is having the other 3 layers, right?
Secretions.
Sorry?
Secreting HCl.
No. Here it is not secreting HCl. HCl will be secreted in stomach. It is different, right? So here, this muscular tube has only 3 layers. The 4th layer is missing, and it has a bearing for our surgery. What is that?
Is it related to contractility?
No.
Movement. Okay.
No, it's not related to movement. Okay. See, in esophagus, if a tumor is there, because this layer is not there in the back, it will spread longitudinally. Okay, it can spread because there is a tough layer outside. If there is a tough layer, it won't spread. Because of the absence of this tough layer outside, it will spread longitudinally along the esophagus. So, if we want to do any surgery in the esophagus, we can never do a partial esophagectomy. Like partial nephrectomy we did yesterday, partial cystectomy we do, but never partial esophagectomy is done. We have to remove the entire esophagus. If there is a small lesion somewhere, upper, middle, or lower, anywhere, we have to remove the entire esophagus. That is the importance of this. Why? Because of the absence of serosal layer, it can spread longitudinally. Due to this, we can never do a partial operation here. If a patient has a esophageal mass or esophageal cancer, he has to undergo what?
Total resection?
Yeah, resection. That is total
Esophagectomy.
Yeah.
esophagectomy. Yeah, esophagectomy. That is the bearing, with the important point regarding the histology. Why total esophagectomy? Why never partial? Is because of the absence of this layer. Clear?
Yes, sir.
Length is okay. Extent is okay. From the pharyngoesophageal junction to the gastroesophageal junction. Histology is okay. And relationship with the diaphragm. So the diaphragm is like this. The diaphragm, upper thorax and lower abdomen. So the diaphragm has 3 openings. 1, 2, and 3. Okay. These are in the first opening, voice of Andhra. I remember it as VOA, voice of Andhra. So V is inferior vena cava. Vein. Inferior vena cava opens above. And then comes the esophagus. And then aorta. These 3 openings are like this. The esophagus opens first, then comes the vena cava opens first, then comes the esophagus, and then comes the aorta. Because diaphragm is not like this. It is a
Dome shape.
Yeah, cone shape. The structure is like this. Okay. So at one level, vena cava opens. Below next level, esophagus opens, and then aorta opens. So the levels are T6, T8, and T10. Remember, T6, T8, and T10. 6, 8, and 10. Easy. Voice of Andhra. 6,
Sir, 1
8.
minute. Actually, that in anatomy they said T8, T10, T12.
T8, T10, and T12. Okay, I'll just once again confirm with that. Okay. So I remember it as 6, 8, 10 because GE junction is at 10, right? Esophagus GE junction is at 10. So I remember it as like that. I'll just confirm and I'll tell you.
Okay, sir.
Okay. Yeah. So then, what is this angle of his? This relationship with diaphragm is important. Then what is this angle of his? If this is the esophagus, this is the stomach.
Can you
Yeah.
please repeat the relation with diaphragm?
Yeah. Yeah, I'll finish this angle of his first. So this is the angle. This angle is there, right? This is the angle known as angle of his. Why is this important? This angle. Just guess.
Because
Sorry,
that's where the stomach.
Yeah. No, if this angle is not maintained, what will happen is there will be
reflux.
Here, what is there in the stomach?
Acidic reflux.
Yeah, HCl is there. If this angle is not maintained properly, then there will be reflux of acidic material into the esophagus, which will cause reflux esophagitis. So the angle of his is to be maintained properly. Okay. So then we'll come again to that relationship with diaphragm. The diaphragm is a conical structure like this. Okay. So it has 3 openings. 1, 2, and 3. So the vena cava opens in the upper opening, vena cava, inferior vena cava. Esophagus opens in the middle opening, and aorta opens in the below distal opening. So it is, I think it is 8, 10, and 12 only. So it is around T8, T10, and T12, the openings. I'll just confirm it once again. Okay, T8, T10, and T12. They are the thoracic vertebral landmarks. At this opening, it is, there are small hiatal openings, so that the vein will pass through it, esophagus will pass through it, and the aorta will pass through it. Is it clear now?
Yes, sir.
Yes, sir. Thank you, sir.
So if this is clear, then we'll move on to the natural constrictions.
Sir, can you repeat the angle of fence once again, sir, please?
Repeat the
If the angle of fence is not maintained, what will happen, sir?
the angle of fence is not maintained. There will be reflex of gastric contents into the esophagus. It should never happen.
Okay, sir.
Esophageal contents are alkaline. Gastric contents are acidic. Okay, if this material goes there, if acidic material gets there, the patient will have heartburn. Reflex esophagitis
Okay,
will
sir.
happen. So if that angle should be maintained properly. Okay. Is okay, right?
Okay, sir.
Yeah. And see here. So I told you there is normal esophagus is there. It has 3 constrictions. One is at the cricopharynx, upper part. Cricopharynx, we call it as cricopharynx. And in between the aortic arch, and the left main bronchus. Both are almost the same, 25 and 27. Some books mention it 25, and some books mention it 27. And even some books mention reverse also, but don't worry about that. In between one constriction, a small thing, either because of the aortic arch compressing or the left main bronchus compressing, either these two, in between it is there. And below the GE junction, 3 openings only, 3 narrowings, one at the above, one at the below, and one in between. So this is at 15 centimeters at the starting, and this is 40 centimeters. In between at 25 and 27, remember 25, at 25 centimeters, you will feel a small narrowing, that is due to aortic arch or left main bronchus. The levels also are not so important. It is C6, you know that it is a T10 lower part, it's a well height. In between at T4 and T5. Okay. This is clear? Yes, no?
Yes.
So the narrowest part of the esophagus out of these 3 is the cricopharynx. It is the narrowest part of the esophagus. So any foreign body is likely to get lodged there only. Okay, if the options are given cricopharynx, aortic arch, esophageal hiatus, you should mark cricopharynx because it is the narrowest opening. First point. And second point, any other thing, while doing endoscopy, something can happen.
Yes, sir.
Perforation can happen.
Yeah, perforation can happen. So this is the most common site to have perforation also. Okay, so 2 points we are discussing. One is most common point for foreign body lodgement and the most common site of esophageal perforation. Yeah, this is clear. This slide is clear.
Yes, sir.
Yeah, so 2 points are, one is foreign body, one is perforation. Both are common at cricopharynx, upper junction only. And we have how many sphincters in esophagus?
2 sphincters.
2
4
sphincters.
to
2
R2.
sphincters. Upper esophageal cricopharyngeal sphincter, this is known as cricopharyngeal sphincter, and the GE sphincter, gastroesophageal sphincter. 2 sphincters are there. See, suppose if the gastroesophageal sphincter, if it relaxes, what will happen? If it fails to relax, what will happen? Just guess and tell. If it relaxes, if it fails to relax. 2 conditions only.
If it fails to relax, then there will be hypermotility.
Hypomotility.
Hyper, right, sir?
If
Too
it fails
much is
to relax, hyper.
hyper. Yeah, fails to relax, hyper. Too much
Okay.
motility. And if
Okay.
it relaxes, then the opposite.
Okay. But okay, correct only. But what will happen? See, this is the stomach here. If
G
it relaxes much, if it is not relaxing, what will happen?
Is this got to do with the reflux, acidic reflux?
Yeah. If it relaxes too much, if the sphincter relaxed too much, what will happen? There will be
Backflow of acid.
black
Stomach
flow of
contents.
acid. So it is called reflex esophagitis. So point number 1. So if it relaxes the sphincter, I am telling what this lower esophageal has a sphincter. The sphincter is always in a tonic contraction. It will be always closed. Whenever there is food bolus in the esophagus, if there is food here, then only it will open. Okay. Other times it should be closed. It should be closed. If sometimes what happens is these sphincters will be defective. So they will be opening all the time. So this will cause acidic reflux. Okay. That is one. And sometimes these sphincters will not relax. Even food is there, they will not relax. Okay. So what is this condition called? If it is failing to relax?
Eclasia cardia.
Yes. Eclasia cardia. Very good. Eclasia cardia. Okay. The lower esophageal sphincter, if it is failing to relax, it is known as eclasia cardia. Okay. Okay. So, any idea what is this Killian's dehiscence? Anatomy? Killian's dehiscence.
Sir, is it related to Killian's triangle?
Killian's triangle. Okay. See, the upper esophageal sphincter, I told you, right? Upper esophageal sphincter and lower esophageal sphincter. Upper esophageal sphincter, lower esophageal sphincter. Lower esophageal sphincter, 2 points, you know, right? If it relaxes, what will happen? If it fails to relax, what will happen? You know. Yes, no?
Yes,
Yes,
sir.
sir.
Yeah. Upper esophageal sphincter, it is having 2 muscles within it. One is the thyro
Thyropharyngeus muscle.
and the other is
Cricopharyngeus.
cricopharyngeus. Yeah. It is a thyropharyngeus muscle like this, it will be there, and cricopharyngeus will be like this. So in between, there is a small dehiscence, that is a point of weakness. So what will happen is the thyropharyngeus and cricopharyngeus, in between there is a small point of weakness. Due to this weakness, there may be, if there is weakness, what will happen? If you increase the pressure inside it, what will happen through the weakness?
It'll open up.
Yeah, it will open up. So it will blow out. It will give a small diverticulum like thing. Okay, this is a small diverticulum. Okay, so this is known as Jenker's diverticulum. Jenker's diverticulum. Okay.
Okay, sir.
Yeah, in between the thyropharyngeus and the cricopharyngeus, we have a small opening. That is a area of weakness because of the arrangement of the muscle fibers. One is arranged like this, and one is having a oblique shape. Because of the arrangement of in between, there is a small gap. In hypermotility, in some patients, what will happen? In normally, nothing will happen. But in some patients, if the pressures in the esophagus are very high, then there will be a small outpoaching or a diverticulum known as Jenker's diverticulum. Okay. And remember one more thing, this upper esophageal sphincter is both anatomical and physiological. That means there is a muscle and there is pressures there. Both are there. But lower esophageal sphincter, it is just a physiological sphincter. That means, what did I mean? Upper esophageal sphincter is anatomy and physiology, both. Lower esophageal sphincter is only physiological, no anatomical, not anatomical. What does that mean?
Only due to physiological reasons, such a thing will occur, like in
Very good.
acidic reflux.
Very good. Yeah, only physiology. There is no specific muscle. The esophagus itself is there, but the pressures in the esophagus, in the lower esophageal sphincter are different. That's why we call it as a sphincter area. But upper, we have a muscle there. We have the thyropharyngeus, we have the cricopharyngeus. They act as sphincter. Clear? Got my point?
Yes, sir.
Others also, please, if you are not understanding, just tell me. Yeah. So upper esophageal sphincter is both anatomical and physiological. Lower esophageal sphincter is only physiological. Upper esophageal sphincter is made up of thyrapharyngeus and cricopharyngeus muscles, two muscles, and there is a small area of weakness there. Lower esophageal sphincter, no muscle at all, because this is just continuation of the esophagus. If it fails to relax, what it is known? Achalasia. If it is relaxing too much, then we call it as reflex esophagitis. Okay. Now, on embryology, this is a small topic from pediatric surgery. I'll just complete it here. There is a entity called tracheoesophageal fistula. Tracheoesophageal fistula. What is a fistula?
It's an opening.
It is an abnormal connection between two organs.
Two
Cylindrical.
Yeah, it is an abnormal connection between two epithelial surfaces. Okay, so here is one tube. This is esophagus, and suppose this is trachea. There is an abnormal connection between these two. It is a congenital anomaly. Okay, this is a congenital anomaly. So there are types like A, B, C, D, E. There are 5 types of tracheoesophageal fistula, and just remember, type C is the most common. Type C is most common tracheoesophageal fistula. Most common. This question has been asked like almost 10 times in the past 15-20 years. Okay, I'll tell you what is this type C. I'll show you the diagram also. But for time being, just remember embryology point. Tracheoesophageal fistula, it is a congenital anomaly. Okay, both the trachea and the esophagus have a connection, and there are many types. Out of this, type C is the most common. Okay, you'll remember this point.
Yes, sir.
Yeah. So, okay, I'll show you the diagram anyway. In the next slides, it is there. I'll show you the diagram. Okay. So, till now the anatomy embryology part is over. So, just this is a little bit complicated thing, and we no need to remember all these pressures and all. But just for your understanding sake, esophagus is a hollow muscular tube. Okay, there is a lot of pressures in this. Okay, so what is study of pressures known as? In esophagus, what is the study of these pressures known as? One study, what is that? Something starts with M.
Very
good.
sure, sir.
Manometry, very good. Manometry. Okay, so this all now it all depends upon the pressures, variation in the pressures. Normal intra-abdominal pressure is 5 to 8 millimeters of mercury. Intra-abdominal. Okay, and normal thoracic pressure is negative pressure. Thorax has a negative pressure. It is -4. It is -4, and it is abdomen. It is positive. And once these pressure levels maintain, there will be no reflex of gastric contents into the esophagus. These pressure levels, if they alter, there is high chance that the gastric contents will get reflexed into the esophagus. You're understanding? So it is just simple. Tell you. Okay. So see, this is the thoracic lungs. This is the esophagus in between. This is the stomach. Okay. So I'm talking about some pressures. One is intra-abdominal pressure, IAP, intra-abdominal pressure. Second is intrathoracic pressure, ITP, intrathoracic pressure. So the pressure differences should be maintained at a level. Okay. If there is alteration in the pressure differences, if there is some pressure difference, fluid will flow. Okay. So in the same way, food will flow from here to here. If there is alteration in the pressure differences, then the food will reflex. Is it clear?
Yes, sir.
Yes, sir.
Yeah, simple. Nothing else. Just remember the pressure should be as prescribed, like 5 to 8 in the abdomen, -4 to -6 in the thorax. If this is altered, there will be imbalance. There will be reflex of contents from below to above. And the most important mechanism to prevent GERD. What is this GERD?
Gastroesophageal
reflex disease.
Yeah. One point I told you. What is the most important point? I told you why GERD happens. Gastroesophageal reflex disorder. Why it happens?
Sphincter relax.
Yeah, if the sphincter relaxes too much, if the sphincter, lower esophageal sphincter is defective, then GERD is bound to happen. Point number 1. Number 2, if the pressures increase, I don't go into that, but if the pressure mechanisms are altered, then also there will be reflex of the contents. Yes? Okay?
Yes, sir.
Yeah. And third point is the angle of hiss, if it is maintained, angle of hiss should be maintained. Okay? The angle of, what is the angle of hiss? It is the angle between the esophagus and the lateral curvature of the stomach. Okay? If the angle of hiss is to be maintained. So, if suppose this is the diaphragm, at least 1 centimeter of the esophagus should lie within the abdomen. Then only the angle of hiss is maintained. Suppose, see, this is the diaphragm, esophagus, and angle of hiss. Okay, what is the difference between both these two?
The angle is not prominent in the second figure.
Yeah, why is it so? What happened to the angle? It got disturbed. Why is it so?
So the
Because-
length, because of the length of esophagus.
Yeah, the length of the intra-abdominal esophagus. Normally, esophagus is an abdominal organ or thoracic organ?
Thoracic.
The thoracic organ, right? But small part of esophagus will go below the diaphragm. It pierces the diaphragm. Okay, it pierces the diaphragm and goes below. So that small part is below. If this small part is not there, then there will be reflex of contents because the angle of hiss is disturbed. So how much part should be there? It should be a minimum of more than 1 centimeter. At least 1 centimeter should be there below. Then only the contents will not get reflexed. Okay. So 3 points you know now. One is the sphincter, one is the pressure, one is the length. Okay. Clear now?
Okay, sir.
Yeah. These 3 are very important. Sphincter, pressure, and length. Because which of these factors, I'll give you one question. See, question number 1 and question number 2 here. Which of these factors which will help to prevent GERD? 1, the sphincter, lower esophageal sphincter. 2, upper esophageal sphincter. 3, the length of the intra-abdominal esophagus. And 4, pressure differences. What is the option?
Is it 2, 3, 4?
No, like which of the factors is not responsible?
The first
only
factor, the
two.
first one.
Upper
Upper esophageal sphincter is
Upper,
not
yeah.
responsible. Yeah. Okay. And recently there was a question. Which of these factors is not responsible for prevention of GERD? So the options were sphincter, the lower esophageal sphincter, pressure differences, intrathoracic esophagus, gastric folds. Now what is the answer?
Can we have the question again, please, sir?
Sorry?
Can we have the question again, please?
Yeah, same question. Which of the following mechanism is not responsible to prevent GERD? Is not responsible to prevent GERD. Sphincter,
Gastric
lower esophageal
folds.
sphincter,
Gastric folds.
pressures, intrathoracic esophagus, gastric folds.
Intrathoracic.
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 Yeah.
Intrathoracic.
This is the answer. Okay, don't get confused. It is not intra-abdominal esophagus. Okay, it is intrathoracic esophagus. And in one book, it is mentioned that the gastric folds, like the gastric folds are there. If you see an endoscopy, I'll show you the image also. There will be small, tiny folds in the stomach. These have a very, very, very minute role to prevent GERD, but they have a role. Okay, they have very minute role, but they have a role. So that is the answer they wanted. Is it clear?
Yes, sir.
Yeah, this
Sir,
is very
can you please
important.
explain
So
that minute role? I still don't understand about the gastric
yeah,
fold stuff.
see, suppose this is the stomach. Gastric folds are there. I'll show you one picture. So you can. See here, see this picture. This in this picture, there are some minute gastric folds are there, right?
Yes, sir.
Yeah. So these folds have a minute role in preventing GERD.
Okay, sir.
Okay. So the major factors are what you all know, what we discussed till now. Those are the three major factors. That is the sphincter pressure and the intra-abdominal length of the esophagus. These are the three major. One minor factor is the gastric folds. They have a little contribution to prevent GERD, but they have a role. Okay, that's why the question they ask clearly, like intrathoracic esophagus. Most of the students got confused and they have put gastric folds. That's why I am repeating it. Okay, there is no
Okay, sir.
intrathoracic esophagus doesn't play any role of to prevent GERD. Okay,
Okay, sir.
is it clear now for you?
Yes, sir. Clear, sir. Thank you.
Yeah. So what is this investigation? Image-based question. What is this investigation being done here?
Gastroendoscopy.
Yeah, endoscopy. Okay. Here, the surgeon or the medical gastro people, they put the scope via the oral cavity into the esophagus and they look into the stomach. Okay. So this is endoscopy. And what is this investigation?
Barium.
No, it's not barium. It is also an endoscopy. It is being inserted orally. Endoscopy is there, and something else is also there here. Something else.
Camera assisted one. Sorry.
Sorry.
No, I got it wrong, sir. I said something like camera assisted.
Sorry. What did you say?
No, I just said camera assisted procedure or something. I mean,
Yeah, camera is there.
obviously it's there. Yeah, but
Yeah, one. This is an endoscopic ultrasound.
so is something piercing the celiac ganglion?
This is an endoscopic ultrasound. Okay. It is piercing, right? We can take a biopsy with it, or we can do an FNAC with it. Okay. Clear?
Clear, sir.
Yeah.
Endoscopic
Yes, sir.
ultrasound. Just remember the picture. And they are putting a small needle also through it. They are doing FNAC. Okay.
Okay, sir.
Yeah. So this you know now. Most common site of esophageal injury by endoscopy. It is cervical. Okay. Most common site of esophageal injury by endoscopy. It is the cervical. And investigation of staging. This I'll tell you later. But just for time being, remember investigation for T and N staging of esophageal cancer is endoscopic ultrasound. Okay. For T and N staging of esophageal cancer is endoscopic ultrasound. Right?
Right, sir.
Yeah. So once you put an endoscopic ultrasound, this is the pattern you look at. Okay. So you'll have the mucosa, submucosa, muscle layer, and serosa. This is not of esophagus because serosa won't be there. But just for your understanding, I have put this. So if you put a endoscope inside and take an ultrasound, this is how it looks. Okay.